I think I have met most of everyone in here, if not worked with y'all. I'm your new Boston Scientific Endo rep. A lot of you may know Scott. He was here for like 20 years, so I have very big shoes to fill. But what I'm here today to talk about is a little bit of Spyglass, and then we'll also go over like what I'm going to do is I'm going to start with the basics of ERCP. I will not spend a lot of time on it, but just to give a quick refresher, and then we'll get into Spyglass from there and let you guys get your hands on it. Just so I kind of gauge the level, who has actually done a Spyglass case before? Okay, that's fine. They're fun. It's fun stuff. So we'll go over why we do Spy, what we use it for, and then we will go through the actual setup for it. So also you guys will get C&E credits for the classes today. Since I'm going to go over the intro to ERCP, you'll get 2 credits, one for that and then one for cholangiogram. So just make sure you don't leave without filling out paperwork. We'll do that in the end. All right. So like I said, I'm not going to drain this, but it's always nice to have a little refresh and look. I know a lot of times we're in these cases all day, every day, and we forget what we're actually doing and looking at from the outside. I know it's always nice to see the devices out of the body, because whenever we're watching it on the screen, we think that we're working in such large areas when really they're so minute. So just a reminder, here is the anatomy that we are working with within ERCPs. Of course, we go down into the duodenum with a duodenoscope. Like so, it is a side-facing scope where your regular EGD scope is front-facing. So it is that side-facing scope so that we are able to cannulate the ampulla. So we have our duodenum, ampulla, gallbladder. Our cystic duct runs into our common bile duct. Our right and left hepatic ducts is where it branches off at the top. If you ever hear any of your physicians talk about a Klatskin's tumor, that's where that's going to happen at that bifurcation. Our common hepatic duct is really the top. The bottom is the common bile duct. Usually they'll call it the same. And then our pancreatic duct that goes into our pancreas. Our pancreas is broken down into 3 parts: the head, the body, and the tail. And you'll hear a lot of times when you're in EUSs them refer to what portion of the pancreas that they are working within. So we kind of refer to all of this area as the pancreobiliary system. So that does include the liver. I think that this slide is actually one of my favorite slides I show whenever doing educations, because we've all been in those ERCPs where they're trying to cannulate, and it's like, why are we not getting in? This is taking forever. It's really frustrating for the staff. It's frustrating for the physician. But here's our answer. Not every ampulla is the same. Not every patient's common bile duct and pancreatic duct connects in the same way. So you can see here, starting with the first one, there could be hardly any of a channel to go through. And so you could see if we're working on that, you're going to have to get it just right to be able to go where you're trying to go. The next one, there could be no channel at all. They could be completely separate. Or the very last one is kind of what we're hoping we're working with, is where we have a little bit of a channel and then we glide into both the common bile duct and the pancreatic duct. And I will not go through all of this. So that is really the gist. So I will go over this real fast because this is helpful whenever we start to talk about getting our forceps down the channel during ERCPs or during Spyglass. Sometimes that can be difficult, and a lot of that has to do with positioning. So I think this slide's really important to know the difference in short position versus long position. Sometimes you may hear your physician refer to this. So you see that's around the curvature of the stomach, and you can see that hard turn. Think about trying to push a wire that's this small and you're trying to get it around that turn. So ideally we would be in short position. We call it, says it looks like a hockey stick. So typically you'll see they'll go down and then you'll see them straighten out, and that's what they're trying to get into. Once again, everyone's anatomy is different, so they may not always be able to get in short position, but that's ideal if we can do that. And that'll say, says that there. So going into SPY, we're going to talk a little bit about, first of all, why. Here's my family. My cat wants to eat my dog at all times. It's a lot of fun. So, what are the 2 reasons we do ERCPs? Stones and strictures, exactly. So breaking those down, every facility that you go to is going to be a little different, especially if it's like a learning facility. These numbers may be a little skewed, but overall, what the studies show is that we are about 80% stones, 20% strictures in doing ERCPs overall. So that's typically probably what you guys see here. I would say about, you're typically going to be a stone case versus a stricture case. So whenever we're thinking about stones versus strictures, in a normal, everyday, in and out case, with stones, we're going to do a balloon sweep. With strictures, we may use a cytology brush. We may do stenting, whether that's plastic or metal. Within the metal stenting, we have fully covered, we have uncovered. It all depends on what the patient's presenting with. Do we think they're a surgical candidate, or is this palliative care? Do they have a diagnosis? And so with SPY, it's exactly the same thing. We're working with solving for stones and strictures. With the stone category, think those really large stones. So I think the clinical studies say it's 2 or over. I say about a 1.5 or over stone. Typically, you're not going to be able to get out with a balloon, even with dilating the ampulla. So we're able to use EHL on that. I'll show you guys. I have an EHL probe, and we will put it down the actual catheter, but the only way to do EHL is with the SPY scope. With EHL, you have to use saline. So saline is the conductor. I like to train anytime you use SPY, just set up saline. It just removes the room for error. Even if you know it's a stricture, just always make sure you're switching that fluid to saline, just so that you never get in a situation where it's not hooked up. So with EHL, it's important to remember you have to have saline. Saline's the conductor for actually blasting the stone. I actually have some fun pictures here. So here we go. So here is a SPY picture where a very large stone, and here is the EHL probe blasting it into pieces. So this is a stone that they were not able to get out with it in one piece. You get the EHL probe. It's really important that with the EHL probe that you are not touching the stone. You actually want to pull back a little. So what I always say is go all the way to the stone, tap it, and then pull back. Because what it's doing is it's conducting energy within that saline, and that's what's causing the combustion of the stone. It's not the actual probe itself. So I see a lot of times people are trying to, get right on it, which makes sense. You think, why would the probe not do the work? So just remember, pull back a little, and it should do all the work for you. Also important to remember whenever you are in a stone case is just for the physician to be conscious of how large of a sphincterotomy they're making. If you think about the saline being the conductor, if we make this huge sphincterotomy, all that saline is going to be running out. It's going to be really hard to keep a tight seal to be able to bust that stone into pieces. Does all that make sense? Resonate to things you've seen? Yeah. So that's a great picture, and like I said, we'll do some hands-on. The other side of it's strictures, and this is where I get really, really passionate about SPY. We joke as reps, we're like the SPY side. No one wants to do Spyglass. Every time it's on the board, everyone's like, ugh, do we really have to do it? I get it. But I always put it back in perspective of the patient on the table, because if it was my family member, if it was me, I would want SPY every single time. The reason being, especially for strictures, is we're trying to get a diagnosis for that patient. And with cytology brushing, on its absolute best day, you're getting a 30% diagnosis. If say they do have cancer, they cannot start any type of treatment until we have a positive diagnosis. It does not matter if they are showing every symptom in the world, if all of their blood work's coming back, it's cancer. Until they have a tissue diagnosis, that patient cannot start treatment. So if you think about doing a cytology brush, it's coming back negative. How many times are you going to have to bring that patient back to continue to brush to get that positive diagnosis? whenever we're using SpyBite to get that diagnosis, it's closer to 90% positive. A true positive being a positive. So what that means for the patient's huge, and being able to get them treated quicker. So that's my spiel on why Spy, as much as it does add some time to the case, yes, it is more difficult than saying just use a cytology brush, but it really does matter for the patient, and it could truly be a life or death procedure for them. So just keep all of that in mind whenever we're doing Spy. So with the Spy itself, this will come in a box all together. You guys keep them in the storage room right across the very one at the end here, on the bottom shelf, and all of the accessories are there as well. We have a couple different types of accessories that you can use with Spyglass. We have the Spy forceps, which of course are just very, very, very teeny tiny biopsy forceps. We have a trapezoid basket for stones. So say they break up that stone and they still are having problems getting it out, they can go in with that trapezoid to kind of grab it and pull it down. And I'll show you guys all of that. And then we have the EHL probe as well. So some of you guys may have been hearing me talk this whole time and you're like, what is Spy? I don't even know what it does. What is it? It is, I think of it as a mini duodenoscope at the end of the day. This is just a very small duodenoscope that you're putting inside of your duodenoscope. So this is what it looks like. The camera mechanism is your blue right here. It has all of the same wheels as your duodenoscope does. Locks, unlocks, you know, you can turn it left, right, up and down. I always like to loosen these wheels whenever you first get it out of the package, just to make sure it's articulating correctly. If you ever get one out of the package and it's not articulating, it may be faulty and you may need to get another one, but that typically does not happen very often. So whenever you get this out of the package, it's going to be all coiled up. I'm sorry, my demo has seen better days. It's broken and everything else. But you have your Spy console. You guys only have one, correct? I think. Yes, so y'all have one console, so just make sure that if you think it is scheduled for a Spy, that the console is in the room with you. And then I did not want to dirty up one of y'all's duodenoscopes, but I have just a sample one that we can do it with. So first things first, we'll turn on Spy. So whenever it turns on, you will then insert with the arrow facing upwards. So arrow up and insert into like that. And typically the light, my demo may not work. It may be so old. Okay. Oh, here we go. It was just sleeping a little. Okay, so typically your light comes on, just so you don't blind yourself or your physician. I like to go ahead and turn that off until we're actually getting started. I like to use a long wire for Spy. Reason being, if not, the wire is going to get lost. Can you do it with a short wire? Yes, I'm sure you probably all have done it with a short wire. It is possible. But if you know you're going to do Spy, I like to use a long wire with it. So just kind of keep that in mind to try to grab that 450 wire for it. So whenever you take it out of the package, you have it hooked up, turn your light off, you will then attach it to your scope, and you want to go wheels to wheels with this. So like I said, this is just a smaller version of your larger scope. So you'll go wheels to wheels, and mine unfortunately is broken. But it's going to be really, really tight, but stretch it over and hook it on there. You then have two adapters here. So you'll see these, and it's really helpful. They actually have it labeled right here, the water droplets. So this is your hookup for not water, but saline. Exactly, saline. So this is where you hook your saline up. This is another controversial, like, you'll go to different places. Everyone does their suction different. I will tell you that. I will tell you how I like to do suction. How I prefer to do it is I like to take a 20 cc syringe. If y'all have one, I can show you.
Do you need to prime the saline tubing?
Yeah. Yep, so once you hook it up, go ahead, give it a press, go ahead and get it pushed through.
How many cc's the same?
Yep. Yep.
Doesn't matter.
No, just till, yeah, just give it a good, you can kind of, well, I guess it only is clear halfway through, but I'd say, 5 or 10 seconds is probably plenty. So what I like to do if anesthesia has extra suction is take a 20 cc syringe, hook it on here. And the reason I put the syringe on here is because if you try to put the tubing straight on, like, you're gonna have to get real creative. You're probably gonna have to cut it. It doesn't fit right. So, and then I take it, I have to do this before. I take that out. And then once you have the blue tubing, you just put your tubing in here and it's gonna suck down onto here, and then it just suctions straight in. Another option is, this is gonna be a little more work for you guys, but you can actually manually suction.
I think that's what we normally.
Okay, yeah, you can manually suction, but if anesthesia does have an extra hookup for you, just stick that tubing, take it off the back, stick that tubing right down in there, and it should work good. Something else I don't have is the Y port. So this is going to come with a little port that you have to hook right here. That port has a locking mechanism on the top, so you will have to unlock it to get your devices down, and then you can lock it tied back onto your devices. There's also an option on that Y port that you can also do suction. That would be physician controlled suction, but I don't think any physicians here use that. So that being said, there's a little white cap, so just shut off that extra piece on the Y port. So we've talked saline, we've talked suction, we have it connected on the side here. What you will then do is take your catheter. Aaron, do you care to be my assistant? If you'll hold that for me. So you will just thread this down your channel like you would do any ERCP device. So it just threads down the wire like so. You guys tell I don't do this stuff. I don't.
It's easier with a bunch of people staring.
Yeah. So guys, how's y'all's day? Any fun plans for the weekend? So you will just do an exchange just like so. So you'll keep it going down. Does it go anywhere? Yeah, so I don't have a locking mechanism, so it's gonna be pushing my wire, but eventually your wire will pop out of your Y port. Okay, so we have the end of it here. So once we are in place, we're going to go up, and at that point, your physician really has control of the scope. They're gonna be the ones getting into place, whether or not they want to use the wire. You know, we were in a case the other day, I think we lost our wire, and the physician was able to get in without the wire. So that is completely up to them, whether or not to go back in with the tome, replace your wire. So the first thing we're going to do is obviously a visual inspection of the bile duct to see what's going on. Say that we visually looked and we are in a stricture case. They are then going to ask for the Spyglass forceps. So get those. And so there are a couple of little tips and tricks I will tell you guys for this.
And you would have turned your light back off.
Yeah. I don't want to blind you guys, but yeah. So your Spyglass forceps are just like any forceps. They're just really, really small and cute.
They look like the little yellow bead. I think it's like a bead upper, and they're like itty bitty as yellow.
You can see how small they are, or you may not be able to because they're so tiny, but that is the Spyglass, so they are very, very small. But you are able to take directed, visualized biopsies so that you're not having to blind biopsy anything. So with any of your accessories, we are over our wire through our port on the actual duodenoscope. All of the spy accessories, like I said, this is a mini duodenoscope, so think of it that way. So any spy accessories are going to go through the spy scope. So our Y port here at the top, it'll have just like a little screw cap, so just make sure it's loosened. You will take your forceps and feed it down just like you would any other scope. No, you're fine. So we'll just continue to feed that down. So we'll see here. Let's just pull our wire to make it easier to see everything. Okay. All right, so there should be close. There we go. So they come out like this. But say this just happened in a case here last week. So say our spy scope is in the duct. We are pushing our force up and the physician's like, it's stuck. It won't go anymore. Here's a couple of troubleshooting things that is going to make the case a lot easier. So once again, we're thinking about how we have the scope positioned, right? We are a scope inside of a scope, and then we are positioned like this. So it's it's not that crazy that something would get stuck, or it may be a hard turn to take. So what you do if your physician is complaining about the spy bite not coming through. The first thing you can try, I do not go this route if I think that they can easily do the other, but they call it walking the dog. So all you're doing is opening and closing again and again while they're trying to feed down the accessory. Does that make sense? So you're just making it go like this to kind of push through. That sometimes may work. I would say that what I'm going to show you next works way more. So if we are in here, sorry.
No, you're okay.
You're such a great Vanna White for me, you know? Okay, so we are in here. Our forceps are somewhere right here. Say we're bent, and where they're probably getting stuck is right here, okay? So where it's bending is probably where those forceps are getting stuck. But your forceps, you have to think, are inside of your catheter. So if your forceps are inside your catheter, what you can do, our catheter's kind of far up there. Okay, so say we're starting like right here. So what you can do is I'm going to say, okay, doc, drive catheter as far as you can. So what that's going to help do, when you're driving that catheter, your forceps are inside your catheter. So this part of the catheter was in the kinked part, now it's here. So now your forceps are driven up. So now we're going to stop again, and now we're going to draw a forcep, and then our forceps are going to pop out right there, and then we're going to pull back to the desired location. Does that make sense? Okay. It's really hard. Whenever someone first explained this to me, they did not have a model, so it's really confusing if you're trying to explain it without anything. But just remember, you want to start as low as you can, push until you meet resistance. As soon as you meet that resistance, drive catheter as far as you can, drive forceps, pull back, okay? So that's the number one thing that I would say you're going to run into with spy bite, and that is the easiest solution. Walking the dog, it might work, it might not, but I just go to that, and it's pretty foolproof. So, any questions about spy bite?
Yeah,
Yes.
can you see on fluoro the bite inside the catheter? Like if we had to drive it so that we know it's absolutely in the catheter?
Yes.
Okay.
Yes, you should be able to.
And then markings?
Can you see it in the catheter? I know you can. I mean, yeah, because you can see it when it's out of the catheter, so you should be able to see through it. Yeah.
I just
Yeah.
didn't know if the catheter
Yeah, because
was
the-
opaque or.
Yep, so the case that we actually just had this in, that we were kind of using fluoro to judge
Yeah.
whether or not what we were seeing.
We'll
So,
know,
yep,
we'll know it's in there.
yep. So, all right. All right, next we will go over EHL. Sorry, guys. Lots of fine chords. Oh my goodness. There we go. Okay.
Yes, I think.
Well, we can look at this. So you guys can pass these around. Same idea. These are just very small accessories. We have a retrieval basket. Show you that retrieval basket. And then we also have a snare. So really, the only reason you're probably going to use the snare is if there is a migrated stent up in the duct. You can use Spy and the snare to get it out. It's pretty effective, so you'll see that. Y'all can pass these around if you want to get your hands on them. There you go. There's that one.
We'll have the guy free one, then you tighten that wide like that.
Yep, yep. So with EHL,
I'm not fully putting.
I have my whole weight on it, so yeah, don't pounce.
so here is your EHL probe. The EHL should always stay on the cart with Spyglass because you cannot use one without the other. Here's your probe. All you have to do is hook it in to the adapter. Make sure, yeah, there's two big holes and there are 3 little ones, so you just match them up like so. Sometimes I get questions about this thing. I think it's just if you want to keep your cords like wrapped up, you can use it to wrap it. It doesn't have anything to do with the actual probe though, so don't worry about it. If you want to, just push it to the back, that's fine too. Same idea as our Spy bite. So whenever we have our wheels to wheels, right there, all we're gonna do is we will take our EHL probe and we will feed it down our Y port. So make sure we just loosen up the top of the Y port. And once, typically these probes, I mean, it's super flimsy. Whenever you feel it, they go down pretty well and you won't have any issues. And you just keep it going until it comes out. Just remember, like I said, with the probe, has to be saline. Just get in the habit, always switch to saline whenever you're using Spy, and make sure that, you know, if you're ever with a physician who doesn't use it very often, or maybe it's their first time, if they're trying to, if they think that if they're trying to make contact with the actual stone, just remind them, pull back a little. It's gonna be much more effective in getting whatever they need out. And then they may do some balloon sweeping after in conjunction with this. So it's really taking a while to get out, isn't it? We should be close. There we go. So it just comes out of the end like so. Are there any questions that y'all can think of? Any situations you've run into? I know a lot of people have not used Spy a lot, but anything top of mind?
What's a typical setting?
For EHL? That's a good question. I'll get back to you on that. I'm not going to pretend to know because I don't.
You just use
Whatever the
like
doctor
What?
tells you.
MD
What
makes
would you like this
decisions.
set on?
Is that a cautery, Michelle? Does that specifically go with the Spy?
The EHL,
What is that?
it's this piece of equipment right here. So it is its own piece of equipment.
like the trip.
Mhm. Yep. Yep. So it is completely separate and goes with
Okay.
Spy. Yep. You only use it with Spy.
Okay.
But it does not have any cautery to answer your question. So it's not bipolar, monopolar. You do not have to have the patient grounded for it. It's like a energy
Electricity.
conductor. So it's
It works with the saline.
yeah. It's like it conducts the energy to blast through.
Okay.
I don't know all the science behind it, but
It's magic.
it It's like Harry Potter, okay? Just believe it.
Is it just your normal gator tubing that connects to the little water port?
Yep. So if you, like I said, the water port, yeah. And then, yeah, saline.
You know what I mean.
Saline. Here, I don't have that anymore. I was supposed to say, would it be helpful, and you guys be honest with me?
Yes, it would be.
If I made a QR code
Oh.
to go on top of there that would take you to a video to set up,
Yeah.
would that be helpful so you could come
We
in
like
here like
QR
10 minutes
code.
before the case and review it? Okay, I'll do that.
Can you make it waterproof?
Yes, I will laminate it. Okay, we'll do a QR
your
code
phone
on there
number.
then. And I'll ask about I'm trying to remember. I knew it one time. I'll ask about the settings. Your physician should know, but just in case.
You have a limited lifespan, so like you can only do so much with it.
Yes, so there are, good point. So there are, y'all think I'm from Selmer? There is a limited number of pulses that the probe can let out. It's in the thousands, I know that. But it is possible that if you have a really big stone or multiple stones that they may kill the probe, for lack of a better term that I can't think of right now, and you may have to pull another one. And in that case, well, you'll be able to tell that it's just not working, and that should not happen until, like, if it's not working at the beginning, there's something wrong. If you've been at it for a minute and then it stops working, it's because the lifespan of the probe has died out, so just grab another one. And with that being said, I would always have 2 in the room if you know you're going to do EHL, just for safekeepings. I would say most cases you get through with 1, but I've definitely seen 2 used.
At the back.
Let's see what it cuts off to. Yeah, it is. Yep. Also with the Spy, once you turn it on, it automatically on setting 3 for light source. I mean, you can mess with it if you want to, I never do. Just one more thing to worry about. But if for some reason you guys have really great screens here, some accounts, like if you have really bad screens, Spy doesn't look as good, but y'all's screens are really good, so usually it looks really good. Okay, so here is, I'm pretty sure this is typically where you actually they usually start on like medium 10, I think. Medium 10. That sounds.
They gonna start on whatever.
They don't start on what you give them. But your physician will know that. So all you got to do is touch screen. There's low, medium, high, and then there's number of pulses. So whenever we were talking about the lifespan of the probe, that's what we're talking. We're talking the number of pulses that it takes. And then here, make sure you give them the foot pedal. So here's the foot pedal. Yep, that's what makes it work.
Do
If
they
you-
need a pad?
Nope.
Okay.
Nope. And the only other thing I will say, if your stone is very distal, so you have this huge stone that's super distal, you're probably going to need to push it up into the duct a little bit. Once again, the conductor of this is saline. So if you have a super distal stone and you're not able to hold that saline in because it's at the very bottom, then you don't have a conductor for the probe to work. So they may want to take the scope and kind of push up on the stone to give you a little bit of room in between. Does that make sense? The most important thing, if you get nothing else out of this, I want you guys to feel comfortable about setup, and I'm going to get you guys a code on here. And then also, if any instruments get stuck, knowing how to walk a physician through how to get them unstuck. Because there's a lot of people that don't know how to do that. Like a lot of doctors, because you don't need it until you need it, right? And so if you've never done it before, it's one of those simple tricks, but it kind of takes some practice to be able to do it. Anything else? Okay. Y'all make sure you